Started, sir.
Okay. Good evening, everyone. Welcome to one and all, everyone, for the International Kangaroo Mother Care webinar that we are going to be having in the next few hours. This is organized by the Kangaroo Mother Care Foundation of India, along with support from NNF Gujarat. So as you can see, Kangaroo Mother Care Foundation began somewhere in 2014-2015 after we had our International Kangaroo Mother Care Workshop in 2012 in Ahmedabad. We are celebrating this, we're doing this webinar for the National Newborn Care Week of India, which runs in this week, and in addition to the World Prematurity Day, which runs on 17 November. KMC Foundation began with actually for the reason for scaling up awareness, advocacy, and the proper practice of KMC and the promotion of KMC related research in India. Our mission is that the mother's chest is the best place for newborn care, and mother's milk is the best food for newborn nutrition. We have our own website where we have our newsletters and various other resources that are available and can be shared by everyone. We are a group of people who work for this particular foundation, and it's a trust with no profit-making enterprise. We have been supporting the government of India and various states in India for ensuring that KMC advocacy is being done. Okay, this thing is supported by Dr. Mohit Sahni and Dr. Snehal Desai of National Neurology Forum of Gujarat. And Dr. Mohit is the president and Dr. Secretary, and Dr. Snehal is the secretary. So they are with us today and helping us ensure that we are able to do the webinar in a successful way. With this, I hand over to Dr. Shashivani, who will be taking over for the next speaker.
Thank you, Dr. Somsekhar. And first of all, I welcome all our speakers today, and particularly our international speakers, Dr. Natalie Charpak and Dr. Niels Bergman. They have been very kind enough to readily accept our invitation to join our webinar today. And as all of you know, we have been promoting kangaroo care to the best possible level, and we want to improve the quality of kangaroo care in India. So far, kangaroo position and kangaroo nutrition.
Madam, you are muted.
Can you hear me now?
Yes, madam. Yes, madam.
Yes. Okay, I welcome all our guest speakers and the participants today for our international webinar. Our main objective has been always to improve the quality and coverage of KMC in India. To some extent, we have achieved a few things, but I thought the element of follow-up and early child development, these are all missing from our concept and definitions of kangaroo mother care in India. And from that angle, I have requested the speakers to put emphasis on that. So, with this brief introduction and thanking all the speakers, Dr. Niels Bergman, Dr. Natalie Charpak, Dr. Ruchi Nanavati, Dr. Rekha Udani, and our guest of honor, Dr. Sumita Ghosh. She has joined in spite of her very busy schedule in Government of India projects, but I am really thankful to all of you for readily accepting our invitations and making this day a very good day for us. Today is a very auspicious day in Gujarat according to our traditional calendar. We call it La Pacham, and all the good things begin on this day, and we are also starting one good project today. Thank you very much, and I now request Dr. Niels Bergman to start the project, to start the program here. Now, Niels Bergman is a very well-known international figure in kangaroo care projects everywhere. He has covered with all his keynote addresses on KMC at all the 6 continents and in many international conferences in KMC. He now researches and promotes KMC for full time. He made a beginning in South Africa with his studies, and then right now he is working as a research affiliate in Karolinska Institute, Stockholm, Sweden. He has graduated from University of Cape Town and has started working in South Africa and then Zimbabwe and now currently in Sweden. And together with his midwife, Agneta Juriso, they had developed and implemented KMC program for premature infants right from birth. And that had resulted in a 5-fold improvement in survival of very low birth weight babies, and subsequently introduced KMC in South Africa, and now of course he is on the international platform. Dr. Niels, please. Today he has chosen a very interesting topic, that is first 1,000 minutes. So far we have been talking about 1,000 hours and 1,000 days, but now he wants to talk about first 1,000 minutes and first 1,000 hours. Dr. Niels, please.
Thank you very much. I shall see that I can master these buttons, and I hope that everybody can see my screen.
Yes, we can see your screen.
The screen should be showing your own logo. Thank you very much for inviting me to this day and to be the first speaker even. So the first 1,000 days begin with the first 1,000 minutes. So let me unpack that first away. Everybody knows about the 1,000 days, 270, 365, times 2 is 1,000. And that's early childhood development. The focus of this attention, however, has always been a year later. And yes, we acknowledge pregnancy, but the 1,000 days actually came from nutritionists. And so they really have the focus, and it's more the second year that has a focus. Now, developmental programming to be particular, determines the outcomes at 2 years. And developmental programming starts much, much earlier. And so I'm depicting that in my arrow here. And now it started at conception, but there's a particular period around about birth. And that's 1,000 minutes for those of you who are mathematically challenged. That's nearly 16 hours, 17 hours. But let's just call it the first day of life. The first 2 years, all very well. But the first day is the focus of my attention. Because at this point in time, there are critical periods operating in development. And a lot of signaling hormones, these are particular hormones that make settings of hormone receptors, cortisol, vasopressin, endorphins, oxytocin, dopamine. They are working at this particular point in time to achieve regulation of the body and connection to mother. And then we have the microbiota, of course, that we shouldn't forget. Now, here at the top of the slide, you see some science that I'm not going to have time to cover today. But the important thing is that it's the environment which determines what epigenes do, how the brain works, and how our behavior and development follows. And then anthropologists tell us nothing an infant can or cannot do makes sense except in the light of mother's body, and no more so than at birth. And at birth, as Shashi mentioned, I started doing kangaroo mother care in 1988. And it's skin-to-skin contact that makes the baby know the baby's epigenes, the baby's genetics, the baby's genome, the baby's development, know that it's in a safe place so that regulation and connection can start. Actually, though, I think the 1,000 minutes are the most important. This actually starts in the first 1,000 seconds. The first hour is when most of these critical things are taking place. If you don't get maternal microbiota in the first hour, you're going to get some other microbiota that's going to kick out the mother microbiota. And you get dysbiosis. And so transition to extrauterine life starts immediately. So a lot of the critical things actually take place in the first 1,000 seconds. But 1,000 minutes, first day, these are when things really get started. So notice that I called it immediate at birth, but now continuous. We don't stop after the first hour. That's a trap that we've fallen into, the first golden hour, and after that we separate. No, after that we continue with skin-to-skin contact, and the immediate at birth continues. And notice how nicely the 1,000 hours is 41.6 days. That's exactly 6 weeks. And so that's the period for consolidating these processes that are so important. So at pregnancy, up to the point of birth, we're prepared for a launch into life. And the first 1,000 days begin from here. You've heard me speak before about zero separation. Now, this is the negative side of the same coin, because here you see the harm that follows not just the baby, but also the mother when separation takes place in these 1,000 seconds and 1,000 minutes. And so very briefly, why zero separation? I'm going to try and condense this as tightly as I can and start with the epigenetics, which are determined by the environment. And I take this from a man called Panksepp and a man called Myron Hofer, who shows in this slide here that the interactions between the parent and the infant, exemplified by kangaroo mother care, achieves regulation. And there are critical periods, there are the hormones, there's the regulation and the connection taking place. Now, when you separate, there is absence of the buffering protection of adult support. And that is the definition of toxic stress. Toxic stress is when it's prolonged and it produces cortisol. Cortisol is producing homeostasis. So we think stable vital signs is good, but if it's prolonged and accomplished by cortisol, it is good in the short term, but not in the long term. And this was the iconic experiment of Michael Meany. Michael Meany did the experiments with rats. I don't have time to explain this very much in detail, but on the right-hand side, you see the HPA, hippocampus, hypothalamic pituitary axis, that produces cortisol. And the receptors are these blue V's on top of the hippocampal surface. And Meany had rats which are high licking grooming, and they produced healthy babies that became healthy offspring. But he also had rats who were otherwise identical, who were unhealthy and produced unhealthy offspring. And the only difference was the number of receptors activated on the surface of their brains. His experiment was to take a baby from the healthy mother and give it to an unhealthy mother. The unhealthy mother produced a stepchild that was unhealthy. And so purely the nature and nurture response effect together of low licking and grooming, as in poor buffering of adult support, produced a poorer phenotype. Early stress alters gene expression by epigenes with health impact across the lifespan. Iconic experiment. Please look into this if you haven't come across it. Now, I want to state, yes, it applies for rats, but we also now know that it applies to humans. And this article on the left-hand side shows that for the last 20 years, our outcomes, despite surfactants and despite corticosteroids, have not improved. And in fact, bronchopulmonary dysplasia is increasing. So here we are. Why zero separation? It produces toxic stress, and it has adverse impact on maternal and on infant outcomes. And the outcome is vulnerability in the first instance. Not everybody is vulnerable, gets sick, but you're more likely to become sick and diseased when you have this vulnerability. In contrast, when in the first 1,000 minutes, I'm back to that at the bottom of the slide just to remind you, we have the baby regulating and the mother sensitizing and breastfeeding established. That's our definition of kangaroo mother care that you heard described just now in the introduction. Then we achieve health, but we achieve resilience, opposite of vulnerability. And this resilience means that we have a much greater chance, assurance of health as opposed to disease. And that green bar at the bottom is a spectrum to show that it's the whole population with more health on one side and less health on the other side, purely related to buffering protection of adult support. Now, I call this nurture science. Nurture is not a scientific word when I was in medical school, but let's understand what it is. Now, part of what I mentioned was the mother's sensitization, and I haven't mentioned her up to now. I need to include her. And here you see sensitivity connections, interactions between the mother and the child that alters the maternal brain to make her more protective to her child. And this applies to a host of hormones. It's the interaction of hormones that makes connections that actually establishes what we call signaling, messages that bond the mother and the infant. It takes 20 hours, 16 hours, 20 hours, one day. There's a lot of circuits in the maternal brain that have to change. A number of different hormones involved. And the key hormone in this picture that you can't see, but the reference I'll provide for you, is dopamine. And the connection of dopamine to oxytocin is what accomplishes resilience, is what accomplishes the capacity to lower cortisol fast. And that is how you define resilience as opposed to vulnerability, because oxytocin, dopamine, and cortisol circuits overlap. And the stronger the reward dopamine circuit is, the more resilience. The stronger the fear circuit is, the more vulnerability. And this is a direct effect of early nurture. And so resilience is defined as the capacity to maintain healthy emotional functioning in the aftermath of a stressful experience. And that is what keeps you healthy. So I've got a summary of nurture science that I've just sketched to you as briefly as I can. And more details are published in these two references. And these slides will be available to you afterwards. I've already sent them to the organizers. So the first 1,000 minutes are determining. I want to just show a little bit also some of the science here. One more step. This is from the focus of attention being very, very early. I'm showing that there are 4 arrows in the first circle and only 1 coming later. It's at the beginning that caregiving, regulatory and buffering systems are critical, established at birth. And the first thing is to know, am I safe? Depending on I'm safe or unsafe, my emotion systems are regulated and my stress biology is regulated. So the top of the hierarchy is threat appraisal. And determined by that, the more buffering you get, the stronger is your emotion regulation. The less buffering you get, the stronger is your stress regulation, as in cortisol. And so resilience is the objective of what we accomplish when we connect oxytocin and dopamine receptors in the first 1,000 minutes of life. This is nurture science. And I'm referring to some of these slides that I showed earlier. So the first 1,000 days begin in the first 1,000 minutes. And this, am I right speaking? I can hear noise. This is nurture science. Now, some people think nurture and science is an oxymoron. These are 2 contradictory words. And so I want to make a very unusual departure at this point. I want to talk about ethics. There are 4 ethical principles. And here we are: non-maleficence, beneficence, justice, and autonomy. And so when I make a decision for an adult, all of these principles have to be considered one by one, and I have to make the best possible weighting of these decisions. Now, non-maleficence is the defining feature of evidence-based medicine. We do randomized controlled trials, and then we make systematic reviews. And the definition of a systematic review is that it lowers risk. So non-maleficence translates into science as risk reduction, as evidence-based medicine. I hope you're okay with that. Beneficence, on the other hand, is doing good, actively doing good. Now, what I want to point out here is that the difference between beneficence and non-maleficence in my nurture science mind map is that risk reduction is what I do when I reduce toxic stress. But it's not enough to reduce toxic stress. It's necessary to nurture. It's necessary to enhance health. Health enhancement requires active, positive support of the processes that are going to accomplish signaling of the hormone connections. Health enhancement requires beneficence actively, not just non-maleficence. And so ensure needed neural processes are taking place. As an active ensure needed neural processes are taking place. So risk reduction, yes, we want to get rid of those bad things that I showed you earlier. Now, justice. This is the ethical principle that every child deserves this. It's about applying health resources equally, distribution, rationing of resources to the whole population. And remember, I spoke about the whole population is benefited by having a policy, a practice in the country that exercises this. Autonomy is the more familiar purposes. We talk about informed consent and privacy. Now, though autonomy might be the most important thing to me and you as an adult, and this carries equal weight actually with all the other principles, for children, this is not so. Children do not have autonomy. And the ethicists have spent a great deal of time after this since the Second World War. And the principle is not that the child has autonomy or that the doctor or the parent has that autonomy. The principle is called the best interests of the child are paramount. It comes from the Convention of the Rights of the Child to protect and promote the rights of children that are necessary to fulfill their needs. Children do have rights, and those rights impose obligations on adults to be advocates for children in exercising and achieving those rights. I'm lifting out this word, an obligation on the adult to be advocates. Are we all right? And so the first 1,000 days begin with the first 1,000 minutes. I'm imposing now as an obligation, and we should advocate for children in this respect at birth, because that's when outcomes are determined. And so I have to make this point because some of these very, very simple things are nice to have, and they're not in anybody's job descriptions. And because of that, we're too busy and we don't have time for nice to haves, and therefore they don't happen. And therefore, in the immediate kangaroo mother care study that we've completed and that we hope to publish very soon, we employed kangaroo mother care supporters to ensure that only those very specific things were done. And so kangaroo mother care, we combined with a concept called the doula. And we call that the kangaroola. They used here a picture of my wife. She's the kangaroola. And they're active processes that require to wire the father's brain at birth. It takes less than an hour to do that. But it takes about 6 hours to wire the baby's brain. And I already mentioned it takes 20 hours to wire a mother's brain. Some mothers come in with wired brains, but a completely new brain can be totally rewired in 20 hours with zero separation. So what does zero separation mean practically? Our time is short, and I'm hoping to share with you a video. It's 90 seconds long, and I'm going to try and keep quiet while I show this video to you.
Jeg får litt mindre mage.
Du så god.
Så. Her det noen som strikker.
Ikke det om Bente, vi har tørre klær.
Ja.
Ja.
Kjempebra.
Det greit å ha tøy sånn?
Jeg bare kjenner det litt på magen.
Ja, det ligger där. Det är klart.
Du er så god.
Ja, nei, den. Jeg er der oppe, kanskje.
Ja, men akkurat.
Ja, det ligger 2.
So what you see in this video is a baby that's 31 weeks gestation. It's been 2 days on corticosteroids because the mother's sick. But it's not an emergency that you're observing. At 15 seconds, you see that plastic has been covered and those towels are warm. At 20 seconds, CPAP has been provided. The father is involved in this. Auscultation before 1 minute shows that the condition is good. At 55 seconds, the monitor has been attached as a result. At 90 seconds, you see maternal connection taking place. And throughout this time, the cord has not been cut. This we can do to a 30-week baby. We can do it to every baby. There's no reason why babies should be separated for any reason. And therefore, 0 separation means immediate at birth. 29 plus 4 in this particular case, 1180 grams. Quickly going to share some few slides. 0 separations means that, yes, I can do this on premature, small, sick babies, but only because it's a normal way of caring for all babies. Every baby should be receiving 0 separation. Yes, now we have small babies and we have sick babies. They need the 0 separation. They need a bit more than that, but they still need 0 separation. They need procedures. And so here you see a procedure being done. The drip is placed while in skin-to-skin contact. Continuous means that phototherapy can be given in skin-to-skin contact. Safe technique is a very important detail, and this technique must secure a patent airway. It must ensure that it continues, and therefore also that maternal sleep is protected and provided, and not just risk reduction, health enhancement. Sleep is absolutely necessary. And therefore, it means that even the smallest and sickest babies are fed and provided access to suckling during skin-to-skin contact and during CPAP. It means we add technology. Whatever technology we have, we add it early on, immediately. CPAP in the video you saw after 20 seconds. It means that we transport infants in this way. And what we've developed in the immediate Kangaroo Mother Care study is the mother NICU. If we're going to have 0 separation, mothers and babies need to be provided care in the same bed. This picture shows a ward round taking place in Safdarjung Hospital by obstetricians and by neonatologists at the very same moment at the same bedside. And therefore, it also means pulling in a new set of people into the neonatal unit called surrogates, whether they're aunties or whether they're grandmothers. In Sweden, they're generally fathers. In our study, we didn't do that, but other than mother should be the family we provide care. Excuse me. It also means the new health carder that I've introduced, the Kangaroo, and somebody who's always at the bedside to make sure that this begins, that ensures safe transport, that ensures feeding taking place, early milk expression. And I want to add the little ethical rider here, that the Kangaroo is the only practical way of achieving justice in terms of ethics, in terms of ensuring that the whole population, even of India, can get this 0 separation. And therefore, this involves profound systems change and immense amount of work that nobody wants to do. Everybody is in favor of progress. Nobody likes change. Nobody wants to change is one of the facts of life. And this is a little bit the reality, for which reason I have felt the need to share with you this ethical injunction. The best interests of the child are paramount. And therefore, the best interests of the child are that the first 1,000 days should begin in the first 1,000 minutes with skin-to-skin contact, Kangaroo Mother Care, and 0 separation. I've kept time. Thank you very much.
Thank you, Dr. Niels Bergman, for an exciting talk. And if people have questions, can you just put them in the chat box so we can answer them there? I would now invite Dr. Parag Dagli to introduce our next speaker, Dr. Natali Charpak. Dr. Parag.
Hi, thank you, Somsekhar. I'm audible, right?
Yes.
Yeah, you're audible.
Okay. So I'm indeed happy to introduce Dr. Natali Charpak. After that excellent lucid storytelling by Dr. Niels Bergman. Dr. Natali is a founder director of Kangaroo Foundation, Bogota, Colombia, where it actually started in 1994. And she's the co-founder of International Network of Kmc Foundation. And she is running excellent follow-up program, particularly in Colombia regarding after Kmc. And she has received many prestigious awards and original research papers on different aspects of Kangaroo, including one which was having a 20-year follow-up of babies who have received Kangaroo mother care at birth and versus traditional care. I hand over to Dr. Natali for her presentation. Thank you.
Dr. Natali, can you go ahead and please share the presentation? Thank you. Dr. Natali, you must be muted. I'm not sure. Can you make sure that?
Yeah, she has started.
Yeah.
Yes. Hello.
Hi.
Hello, hello.
Can see.
Hello from Colombia. Can you see my screen?
Yes, we can see the screen. We can see you and we can hear you. Please go ahead.
Okay. So I will say that as usual, you did not give me easy talk because follow-up is a heavy topic. But I will try to go through the follow-up very quickly. So let's begin. Thank you for this invitation and thank you for inviting me to speak on this topic, because usually I am more teaching this topic but not speaking, so it's a little bit different. So I am going to show you how is the structure of the Kangaroo Mother Care Program, where we are doing the follow-up here in Colombia, and the experience finally of more than 25 years in this follow-up. So, it's not, let me see why. You were right. I don't know why. Give me 1 second.
Yeah, can you click in the middle of the screen? Yeah.
Yeah, normally I will say, I will do it like this if it's not possible. I mean, a group of activities that we are using to implement the Kangaroo Mother Care intervention, and we are following the Kangaroo Mother Care method. If I can just explain it like this. The Kangaroo Mother Care method, I mean, you are practicing that. It's, as Niels says, a kangaroo position, ideally 24 hours a day, beginning as soon as possible, at birth if it's possible, kangaroo nutrition based on breastfeeding, and the discharge policy, which is an early discharge with a close and strict outpatient follow-up, up to 40 weeks, then from 40 weeks to 1 year of coveted age. The target population, all the infants, less than 37 weeks or less than, I think that's very important, of less than, let me move that because, of less than 2.5 kg. Why I'm saying that? Because they are all going in the kangaroo follow-up. We are accepting all these target population. So the kangaroo position, the kangaroo nutrition, and the kangaroo follow-up. And here you have some photos of your kangaroo follow-up a lot of years ago, but I'm sure that Dr. Reka will present it, will present her follow-up. So we are following these technical guidelines from the Health Ministry of Colombia, and they were updated in 2017 with especially the nutritional part. So we all are following these guidelines, these official guidelines, and it allows us, because in these guidelines, we have a table with all the activities defined by the Health Ministry that we must give to a baby, a premature baby or low birth weight infant, that he must receive during the follow-up. So what is interesting is that we were able to put a price to each of these activities, then to do a kangaroo package, then to offer it to health insurance, private or public health insurance. So there is actually 60 kangaroo mother care program in Colombia and fighting for health insurance to respect the package. And that's very important. And the cost in Colombia from birth to 1 year is around $1,000. I want to be clear that it's not the price with neonatology. It is only the price of the kangaroo program. And with kangaroo, we were able to demonstrate to health insurance that we were decreasing time of hospitalization in overall, in average 10 days. So 10 days is more than the cost of the kangaroo program up to 1 year. So actually, I am not going to speak about that, but we are probably the kangaroo package is a very important step to be able to develop a kangaroo program and a follow-up at least up to 1 year. How is the intervention actually? How is the intervention? You can see here, I try to put this because it's very different of the original intervention as it was created in Colombia. I mean, you are doing kangaroo even if you do resuscitation immediately after delivery, and I think that the video of Niels showed it very well. You are doing kangaroo to refer the baby. You are doing, if the baby is stable, you put it immediately with the mother. In the neonatal care unit, you will use kangaroo. In intensive care and intermediate care, eventually you have a ward. And then you do on discharge in Colombia in Kmc with a follow-up program. So there is all a logical progression in the implementation of kangaroo since birth. And you begin with the skin contact, then the breastfeeding, you empower the mother and the family, then you do the home discharge. Yes, and I'm not going to speak about the intra-hospitalized kangaroo because there is no time for that. And I believe that this part of the kangaroo, you are doing it very well. We must try to give to the family the tools to do kangaroo, and to do kangaroo if possible 24 hours. You can see on the photo that in Colombia, the chairs are not very comfortable, but they are going to do at least 12 hours, and if they do it well, they go home. Because what we are doing is preparation of kangaroo in the unit to give the early discharge. We are transferring the care to the family, and when they are feeling that they are able, they will go home if the baby is growing well in the unit. So you can see here photos of the preparation in the neonatal unit in the teaching hospital. So we begin as soon as possible at birth in delivery room. Then we continue here, and we are here. It's a photo that I took in your country. That's in Spain. That's in Colombia. So the first 2 days we are going to train the mother, to teach the mother how to do kangaroo. Then the third day, we are waiting for the mother to be able to do it. So when she's trained, she will go home. And we train the father too, yes. So you can see here photos that I took when I was in your country. I have a lot of admiration. So we transfer to the family. There is a lot of text in my slides, but I will let the slides. So to you, it's not a problem. You can just ask me the presentation. So we transfer to the family all the knowledge to be able to care the baby at home. So all this part of kangaroo at home is really a very important component for us. Yes, it's like home neonatology, if I can say. It's a little bit, yes. So we adapt the mother in the unit, then she will go home. In average, they are coming, they will come in the program, and we know that we are asking a lot to them, but it's only for a short time. So they will do it. And anyway, when the baby was hospitalized, we were asking them to come each day too. So where are we implementing the Kangaroo program? We are implementing it in a hospital. I want to say that Bogota has 50 units, neonatal unit, but only 15 Kangaroo mother care program, because you cannot implement a Kangaroo mother care program in all the hospital. It's not cost effective. So we need a volume to be able to do what we are doing. Yes, and we are doing it in hospital. Yes, because if you have an emergency, it's a neonatal emergency, and it's important to work with people able to manage this newborn. Yes, and we have a multidisciplinary team with pediatrician, nurse, psychologist, social worker. That's the nucleus of the Kangaroo program. So we have eligibility criteria for discharge for the infant, for the mother, and for the family. I'm not going to describe them, but here are the 3 slides describing this child criteria. So you have criteria for the child, of course. So he must demonstrate adequate weight gain with kangaroo and the incubator eventually for at least 3 days. Yes, if he's older than 10 days, he mustn't have any treatment. Eventually in Colombia, he can have oxygen because of dysplasia. He must be breastfed and or able to be fed by the mother. And there is a kangaroo program available to offer a follow-up. Yeah, that's very important. And you regulate temperature in kangaroo position. For the mother, there is criteria for discharge. She accepts to participate, to come back. She was able to manage her baby. She's feeling she's able to take care of her baby. She doesn't have any drugs, any this kind of problem, and she must have the support of her family. And there is criteria of the family. The family must be agreed that the mother is not coming back home to work. Yes, to work for her baby. She will carry the baby 24 hours. The family must be trained to help her when she's going to take a shower, when she's perhaps she needs to go to the bathroom. They must understand the method. So that's very important. The family must be agreed to help, because if not, it can be really dangerous. Yeah, so yes, we have criteria. You can see here a photo at home in Colombia. It's a mother with her kangaroo baby. The father was coming back from the work, and he was carrying the baby, his little daughter, while the mother was able to go to the bathroom to take the shower and all personal things. So it is very important. So the other thing, we are doing it in a big room, the Kangaroo program, but of course the consultation, the clinical assessment will be individual. Yes, but it allows us to teach to all the people in the room, and that's very important. Sick children, we will see them outside because we have 25% of infants with oxygen. Yes, and this open consultation, this group consultation, it allows us to manage better the anxiety of the parents, to teach them each time to repeat what they must do at home. We can ask all the kangaroo mother to explain how to do. They can discuss between themselves. And we know that it's another time. We know it's demanding for the parents to come for a few days each day. Yes, but after, I mean, if they are in the unit, we do the same. Yes, only for a few days. After, it will be each week. So you can see this kind of consultation. This one is in Madagascar, in Colombia. And here is all the team of the Medellin Kangaroo program. So there is 2 steps in the ambulatory follow-up, up to 40 weeks, and from 40 weeks up to 1 year. For us, 40 weeks is very important. You cut another time the umbilical cord, yes, because it's a very special date, and we are going to explain it to the parent that the work is going to be very heavy up to 40 weeks. Yes, but the benefits, it's for all the life of the baby and their life too. So we have to be agree on the cut point of 40 weeks. Yes, it's in agreement between the team and the parents. Yes, we will look at the last, the first sonography in the first trimester, the last menstrual date, the BALAR, and we will agree on this date. Yes, we are of course looking at anthropometric parameter, full clinical assessment. We will ask for brain sonography and ophthalmological screening. We are looking how the baby is taking the breast, how the mother is managing to breastfeed her baby, because we must be sure that everything is well done. We will look if the baby needs oxygen and if there is support, and she will go home with her baby. The LICRA band is very important for us, because without, she will not carry the baby 24 hours. So after discharge, our goal is 15 grams per kg per day up to 37 weeks. Then from 37 to 40 weeks is 8 to 11 grams per kg per day, 8.8 centimeter, and head circumference 0.5 to 0.8. We just accept that the baby can lose weight in the first 10 days. When they are going at home at 6 hours, because sometimes or in the first 24 hours, so we have to wait. What are we going to do with the weight? The most important thing is to do the course, because we do a routine follow-up. So look at that. You can see here that what it was, this curve, I can share them with you without any problem. It was not easy. Here it was in weeks, and here it is in months. Here you have the Fenton curves, and here you have the WHO curves. So this is a unique graphic we are using, and it allows us to see how the baby is growing. That's very important. We have it for weight, for height, and the head circumference. So if doing the curve is really something very important. So we have different strategies when the weight gain is not adequate. We will use a hind milk technique. We will look if the mother is carrying her baby in kangaroo position. Because if she's not carrying the baby in kangaroo position, we will see it immediately because the baby will use the milk to be warm, so it will not grow. Yes, and finally at the end, if she's not, we can decide to use fortifier or preterm formula. So we will repeat the advice on childcare when the parents are coming to the follow-up. On bathing, we don't bath the baby up the moment he's regulating temperature outside the position. Yes, we explain the mother that she can move, of course, she can move at home, she can do small activities, and to sleep, her or the father, we ask them 15, 30 degree, not semi-sitting, but at least 15 and 30 degrees to reduce the risk of apnea and reflux. We publish this year a systematic review on kangaroo and apnea and kangaroo and duration of kangaroo mother care, showing that if the mother can carry the baby more time, the baby will grow better. So 24 hours is very important. The duration, up the moment the baby is asking to go out, when he's regulating temperature, he is not comfortable and he will sweat and he will cry and he will ask to go out. Neurological assessment at 40 weeks, we are doing the Amiel-Kisson test. So I know that pediatricians are doing neurological tests, but the important thing is to be able to do a systematic one so you are able to see how is your cohort. So we are using this one who allow us to look at the active and passive tone of the axis and of the neck, and it was really a good instrument, a good tool to have an idea of what can happen. This thing is with 19,000 infants, is just to show you when the baby is asking to go out. Look, it's a Gauss curve, 38 weeks, 2.5. At this moment, the baby is not agreed. So if you have a 38 weeks and is 1.5, he will fight very soon to go out because he has a maturation to regulate temperature. So it's not easy. He can be very little and not agree to stay in the kangaroo position. And we do ophthalmological screening because really it's something very important. I mean, to avoid the rope. Yeah, I mean, the rope, the retinopathy of prematurity was the first reason of blind infants in South America a few years ago. So it's really something very important. The high-risk follow-up. So here I am going to go very quickly because the time is running. It's not easy to do this in 25 minutes. So we are looking to do somatic growth, detection of audition, ophthalmological, neurological, and psychomotor sequels. Yeah. So of course, physical examination. After 40 weeks, the baby will come each 1 month and a half. We will look at the somatic growth. We will introduce the complementary feeding. So that's very important to use the curves. That's a photo from your country too. To use these curves of WHO because you already have a vision how the baby was here, and here we just put the WHO curve. So you will see if the baby is growing well or not. Between 4 months and 6 months of corrected age, if he's not going well, we will begin the complementary food. We will not give artificial milk. Yeah. So we are looking at the neuromotor. Yes. So we have this sign from the Amiel-Kisson test. The only one we have to wait at least 3 months to have it is a stretch reflex of the foot, but all the others we can have them and look at them during the follow-up. But we are doing the Infanib too. I am not going, I will just go through the Infanib now because there is no time. I want to show you the Griffiths too, but I can tell you we choose the Infanib because it has a good specificity and sensitivity, and especially when you have a high rotation of people. And what is interesting is good to detect something not normal. And it's what we want. So we are doing it at 3, 6, 9, and 12 months of corrected age. So if something is not normal, we immediately begin physical therapy. Yeah. So Kangaroo and cognitive development. I mean, we choose. You must understand that you have the education of the family is something very special. So if you teach well since the beginning, you will have a high stimulation for child development by this family. Yeah, this kind of care, like Kangaroo care, it's really something who can modify family environment and paternal involvement. Yeah, and it help. I mean, that's resilience. So resilience from prematurity, that's very important. Yes, so let's go. Sorry, but I want to show you some little things. So the Griffey Mental Development Scale 2, there is one advantage. It's free and legal. Yeah, so it's very difficult to find it since it's free. And now you have a Griffith 3 and Griffith 4 to sell them. But the 2 is legal and free. And it's interesting because it will look at all this. You have 1 to 5 subscale: locomotor, personal, social, hearing and language, hand coordination and performance. So we are looking at that. We are looking with the mother. We are giving exercise. Yes, it takes 40 minutes. You can see if the mother knows her baby, if she is a primary caregiver. Yes, and it is the little toys are not expensive. Yes, so we use one scale of the Bailey 2, which is free 2 for the behavior. So I will let you the presentation. So we do immunization. We are using hexacin actually, yeah, and acellular pertussis. So let's go on, and we are doing the rotavirus 2 is not there, but we are doing the rotavirus now. So, and I wanted just to show, I have 1 minute, I will show you just some result of the 43,000 infants we have. Don't look here, I just look by gestational age or weight, or if they have oxygen, if they are the poorest, if they are the richest. So the global on 43,000 between 2001 and 2020 in the Excellence Center, I will just show you the sequels. I mean, they are high-risk baby. So look at that. I mean, these babies here, they did have surgery, laser. So we avoid blind infant, 5% of the less than 30, 6% of the less than 1,000. So that's why it's so important, yes, to do that during the follow-up and to choose at which moment you are going to do it to all of them. So somatic growth with these rules, look, 3 kilo, here nearly 9 kilo, actually it's 9 kilo at 1 year of corrected age, everything is at corrected age. Yes, 72 centimeter and 45, that's okay. Of course, the more little is the one than the less than 1,000 because I have intrauterine growth retardation very often. Yes, so neurological exam, look how it grow here, then it go down. Because we do intervention, you have a brain growing, it's exactly the good moment. So you must detect any variation in the neurological exam to be able to do the early intervention. Look here, I mean, it's very important. Yes, and there is equity. It's nearly the same when they are the poorest or the richest. That's the IQ. So you have more problem, of course, when they are more immature, when you have intrauterine growth retardation, or they are less than 30. Audiometry, you have baby with a decrease of the audition. And we have problem here. You know, myopia. If you have a baby with myopia, he will have a delay in the psychomotor development just because he needs glasses. So breastfeeding, of course, Kangaroo is helping, but mothers are working at 3 months, so it's not easy. Loss to follow-up around 20%. And readmission, it's a high-risk follow-up. That's evident. You cannot, so for this reason, the follow-up is so important. And vaccine. Thank you very much. I finish.
Thank you very much, Dr. Nathalie.
Thank
You
you.
have given some of the very important points which I wanted here. And I do appreciate the time was very short, but still it was very, very useful to us. And we will have the question answers in the end. Please.
So we are going ahead with the next talk. Actually, it's going to be a joint talk by Dr. Rekha Udani and Dr. Ruchi Nanavati. Both of them were working in KEM hospital. Dr. Rekha Udani has since retired and then worked in D.Y. Patil Medical College, and currently Dr. Ruchi Nanavati heads the SGS Medical College. Dr. Rekha Udani and Dr. Ruchi Nanavati, both of them have worked together and began doing a lot of KMC related work and research which has been published. Dr. Rekha Udani has published more than 180 papers so far and has had more than 250 to 300 research papers. She is a recipient of the Hens Fellowship in Neonatology and also the gold medal in the National Neonatology Conference as well as in the NNF conferences. She was actually one of the steering committee members of the international networking in Kangaroo Mother Care, the one which was founded along with Dr. Nathalie Charpak and others. And Dr. Ruchi Nanavati is the current of department. Yes, wait, ma'am. Yeah, just a minute, ma'am. And she would be following up with, after Dr. Udani completes. Just hold on, ma'am. Yeah, go ahead, ma'am.
Dhaval. Oh, Dhaval.
Madam, we can hear you. Madam, we can hear you. You can go ahead. We can hear you.
Good evening, my friends. I am thankful to the organizers for inviting me to speak on Kangaroo Mother Care Follow-up Program at KEM Hospital in India. Kangaroo Mother Care Early Discharge and Regular Follow-up is the third component of Kangaroo Mother Care, which all of you know, and it is an alternative to prolonged hospitalization required in conventional care. Kangaroo Mother Care Follow-up has not been paid much attention so far. It needs to be promoted more aggressively so as to achieve successful outcome in terms of quality survival of our high-risk, low-birth weight babies and reduction in mortality. KEM Hospital was chosen as Center of Excellence by Bill and Melinda Gates Foundation and received the grants from them. Survival of preterms exponentially increasing in India, and attention to long-term consequences and minimizing disability is essential. Preterm survivors in low birth weight infants more frequently exhibit neurological and behavioral impairment, cognitive deficits, poor academic performance, or attention problems later in life. Kmc follow-up is needed to monitor general well-being and adequate physical growth, to assess neuromotor, neurosensory, and psychomotor development, also to detect illness at early stages and initiate proper management, to ensure that the mother has understood advice regarding administration of supplementary micronutrients like iron, calcium, and vitamins, and for compliance of immunization, and to make sure that mother and helpers can recognize danger signs and seek prompt care at suitable level. This lecture will cover Kmc implementation, challenges faced, requirement for follow-up clinic, and key messages for successful follow-up. Kangaroo mother care was started after reading through literature in the year 2000. Randomized controlled trial was planned on kangaroo mother care, and kangaroo bag was created. In 2003, a team of doctor and nurse went to Bogota and learned about good practices of kangaroo mother care. After coming from Bogota, 6 sensitization seminars were held at KM Hospital for healthcare providers looking after mother and child, and developed training material. In 2004, grants came from the SNL for KMC application for high-risk, low birth weight babies in KM Hospital, all areas of mother and children, KMC dissemination, and ambulatory KMC. Mothers after discharge go home, and they are asked to continue kangaroo mother care and come for follow-up clinic. And this is the way one can allow the baby to reach at 40 weeks of gestation, and for the small for gestational age babies to reach 2,500 grams, and then they are followed up after they become full term or they become 2,500 grams. For implementation, KMC committee was formed, KMC proposal was made asking permission to implement and also to accept the grants. Made authorities understand the importance of kangaroo mother care and application for survival of high-risk low birth weight babies. File was not moving. So personal follow-up of file at each stage for moving from one table to another table to hasten the process. Because SNL had given the guidelines and calendar for working. Monthly meeting of KMC committee members were met to resolve the problems.
Excuse me, madam, this is
Great
Mohit.
challenge was there that to search for the place, administration section for the proposal, and approval by various departments, and accepting the grant took about 9 months. Then for renovation of ambulatory KMC, appointment of architect, sanction of plan, renovation of temporary KMC, and permission took another 13 months. So ultimately, the location has to be away from the hospital environment to prevent exposure of small babies to infection, which I had seen in Bogota. Several rounds were made in and around KM Hospital to find the place. Then at the end, we found one unutilized storeroom which had 10 corners, and we decided to have because it was away from the hospital environment. Kangaroo Ambulatory Care Center was implemented with the personnel trained in KMC and recruited project manager, 4 staff nurses, 1 medical social worker, 1 data operator, and all of them were trained for kangaroo mother care, breastfeeding and lactation management, equipments, furniture, supplies of drugs, stationery, audiovisual facilities were made available. Inauguration of temporary KMC was made here. This is the temporary KMC. We could manage all the furniture from the stores of KM Hospital and started, and later after renovation, inauguration was done on our Independence Day, 15th August. This is our renovated KMC. Separate areas were allocated like registration, then the growth monitoring where the height and length and the head circumference done, examination and counseling, then early intervention area, breastfeeding area, and this is the waiting area where the health talk was given. During every follow-up visit, details about KMC given in hours at home, details about breastfeeding, growth assessment and monitoring using appropriate growth chart, developmental assessment, illnesses if any, availability of sufficient stock of supplements, proper immunization, mother's concern, spatial follow-up visits for hearing and visual estimation, and USG. Generally, sonography is done at the time of discharge, but maybe afterwards. And next follow-up visit date is given. This is the KMC chart. You can see where the every day mother has to write how many hours she has given KMC. And this is the dances chart where the growth was monitoring. We had given pink pro forma and booklet for the female KMC baby and blue for the male KMC babies. Almost about 700 to 1,000 babies were given KMC from 2005 to 2009, and those babies, almost about 64% to 78% babies were followed up. 50 workshops, 50 training programs, and guest lectures were given during the period, and pediatricians, obstetricians, community healthcare providers, and nursing personnel were trained and targeted mainly the medical colleges, Western and Southern India. Training material, modular training was applied, and this is the booklets for educating the doctor, educating the nurses and the healthcare personnel. Community was educated by way of newspapers, printing media in different languages. So the key to successful Kangaroo Mother Care, our Shishughar, we named that is Shishughar, because there was a dedicated staff for KMC implementation at all the places like labor room, PNC, ward, NICU, transitional care. And all these KMC babies, mothers were given training material with a very easy language with pictures to understand it. Follow-up was dedicated to only KMC babies of KM Hospital, frequent counseling of mothers and family members, health talk to relatives by sister in charge in NICU. Before discharge, relatives were asked to visit KMC follow-up center. Emphasis was given on KMC proper, KMC position, duration as long as possible, preferably 24 hours, breastfeeding, and regular follow-up at each visit. Health talk by the nurse and showing video almost every 2 to 3 times a day for the relatives. Follow-up next visit dates are given and recorded in diary as well as in the booklet. If they do not report on the follow-up day, then they were contacted to visit, and if not affording, then they were paid for transport. In case baby is sick, were asked to visit NICU, and in NICU, babies were seen on priority basis. Rewards were given for successful KMC duration, exclusive breastfeeding, weight gain, and regular follow-up. These are the research which was done during the period of 2001 to 2007. Experience and research proved that KMC and KMC follow-up need replication all over India to achieve Millennium Development Goal and quality survival. KMC is a team. My acknowledgements are due to Bill and Melinda Gates Foundation, Municipal Corporation of Greater Mumbai, KM Hospital, resident doctors, nursing staff, KMC mothers and family members. Thank you very much.
Thank you, Dr. Rekha Odani. Yes, Somsekhar, please go ahead.
Madam Mudani, can you stop sharing so Dr. Ruchi Nanavati can begin doing a presentation? Dr. Nanavati, can you please go on? So as I mentioned earlier, Dr. Ruchi Nanavati has taken over from Dr. Rekha Udane, and she continues the head the hospital of the Department of Neonatology at KM Hospital and St. J.S. Medical College, Mumbai. She is also the head of the Western India Resource Center for Facility-Based Newborn Care Initiative, where they are involved in training doctors from all the Western regions of India in NICU care. Madam, can you please go ahead and share your presentation?
Hello.
I have to start. Yeah.
Yeah, am I audible now?
Yes, ma'am, you're audible and we can see you also. Please begin.
Okay, thank you. Yeah. Very good evening. Respected Dr. Bergman, Dr. Natali Charpa, Dr. Shashivani, Dr. Rekha Udani, my dear colleagues and friends. At the outset, I would like to thank Kangaroo Mother Care Foundation India and NNF Gujarat for organizing today's international webinar on Kangaroo Mother Care and for inviting me to talk on follow-up program at KM Hospital. I bring the greetings from St. J.S. Medical College and KM Hospital, the twin institutions of reputed twin institutions of Mumbai, who have served to humanity for more than 94 years. So the credit of Kangaroo Mother Care follow-up program at our institution goes to, mainly Dr. Natali Charpak, who has been kind enough to come all the way from Colombia, Bogota to KM Hospital, and she has trained us in art and science of Kangaroo Mother Care. Dr. Rekha Udani, we have already heard Dr. Rekha Udani and our sister Rekha Samant. They were trained in Colombia for 3 weeks in the year 2003, and subsequently Madam established Kangaroo Mother Care at KM Hospital. And Rekha Samant, she led the team of nurses and did a wonderful job in implementation of KMC amongst the nurses. Now, the program took momentum when our student, Dr. Suman Rao, a student then, now she's a consultant for WHO, that she did a randomized control trial on Kangaroo Mother Care. And we saw that the babies who received Kangaroo Mother Care had better growth parameters, weight, length, and head circumference as compared to the infants who received conventional medical care. And all the parameters, they were statistically significantly better in the infants who received KMC. And also the morbidities associated in low birth weight infants like hypothermia, hypoglycemia, apnea, sepsis, everything was significantly less in the babies who received Kangaroo Mother Care. And this particular randomized control trial really gave momentum to the implementation of KMC at our institution, and we went ahead with the follow-up care program. And all of us know that, the preterm birth actually desynchronizes the baby's development of cerebral and cerebellar pathways. The most important period is from 20 weeks of gestation up to 45 weeks of gestation. That is disrupted because of the because of the preterm birth. And Kangaroo Mother Care re-establishes the synchrony between the mother and the fetus, which is interrupted by preterm birth. And we know that the application of KMC coincides with the third trimester induction of genetically programmed myelination and sensory driven functional connectivity. And that's why Kangaroo Mother Care is something so beautiful for the babies, because it satisfies all 5 senses of a preterm infant. We know that the preterm survival, even today, have a lot of issues. They have neurodevelopmental impairment. there are cognitive impairment, emotional disturbances, and what we now described as a preterm encephalopathy. With advances in neonatology, sophisticated, equipments, treatment, everything, the overall, incidence of neurodevelopmental impairment has not changed over the decades. So what do we require for these babies? For their better neurodevelopmental outcome, we require a good follow-up care program to see that these babies achieve intact survival. And this follow-up care program is a third component of Kangaroo Mother Care, which is relatively neglected component of Kangaroo Mother Care. And especially in our country, we require to work on it still more and see that it reaches all parts of the country. Now, as Madam has already said, when we decided for the implementation of a follow-up care program, we selected a place which was not in the busy environment of the hospital, but it was in the residential premises. And we started with a temporary Kangaroo Mother Care in the year 2004. And in 2005, we renovated it with the grants received from Bill and Melinda Gates Foundation. And we had a state-of-art Kangaroo Mother Care unit, which had a mother's waiting area. There was a nursing station, which Madam has already showed you. And there was a counseling station, therapy room for the occupational therapist, and a breastfeeding room. So we had a good infrastructure for Kangaroo Mother Care. We had the educational material we prepared in different local languages, Marathi, Gujarati, Hindi, and also prepared a training manual for the nurses and doctors. And we had every policy documented what we are going to do for these babies when they come for follow-up. This we have already seen that we had separate baby record sheets and the baby booklets which were given to them. And in our policies, we had clearly stated that which babies are going to come for follow-up, who is going to follow them up, what will be the place of follow-up, what are going to be the scheduled visits, how do we follow up, and what do we do with these babies. Now, these were the criteria selected by us for their high-risk infants to come to Kangaroo Mother Care Center. So all extremely low birth weight and very low birth weight babies. The babies who had neurological disorders like asphyxia, IVH, meningitis, or any baby who was neurologically abnormal on discharge, the babies who had hypoglycemia with convulsions, the babies with neonatal sepsis, and babies with jaundice who required exchange transfusion. We had a team of doctors and nurses and developmental psychologists, therapists, and medical social worker. Everyone worked together for the welfare of the baby. So this is very, very important. This is in fact a first step in the developmental follow-up program, that we have a teamwork going on. These were our follow-up schedule, that the first visit we asked the mother to come back with the baby in first 2 to 3 days after discharge from NICU, to ensure that transition from hospital to home is smooth, because in hospital you have so many doctors and nurses, the mother has moral support. At the home, she is the neonatologist for the baby. So just to make sure that everything is going properly, we call the mother 2 to 3 days after discharge. Then twice a week till the weight gain was 15 grams per kg per day, subsequently weekly till 40 weeks of gestation, and subsequent visits were at the corrected age of 6 weeks, 3 months, 6 months, and longitudinally up to 5 years of age. Now in the follow-up clinic, we have already seen that the components of follow-up clinic are assessment of growth and nutrition, neuromotor assessment, neurodevelopmental assessment, neurosensory assessment, neuroimaging if required, anticipatory guidance to the patients, and record keeping. Now, record keeping is another very, very important, because these babies are going to come to you for a longitudinal follow-up, and one requires a good record keeping system. Now, as far as the neuromotor assessment is concerned, we initially used Amiltison, which is, all of us are aware of Amiltison technique. This is a good screening test, and the predictive value at 3 months for the normal development at 12 months is more than 93%. But we know that it doesn't tell us about the mental development of the baby, and for that you require the developmental scale. So initially we used Amiltison, then subsequently, after we had training from, the Bogota team, we also started using Infanic, that is Infant Neurological International Battery System for assessment of neuromotor function of the babies. This is a good screening test. It is more objective. It has got 20 items, and you can easily apply it in a busy office practice. And when the studies have done, it has shown that the results with Infanip technique are comparable with that of Ameltison technique. So we currently use Infanip technique also in our unit, which looks at, the French angle spasticity, looks at the head trunk motor development, vestibular thing, and other parameters. Now with all this, this thing, you have to do the neurodevelopmental assessment because you require to look at the other domains. So motor domain, the neuromotor system assessment can tell you, but you also require to look at what is the language development, what is the adaptive development, and what is the personal social behavior like feeding, sleeping habits, bladder bowel habits, ability of the baby to play, adapt to the regulations. And for that you require neurodevelopmental assessment. And currently we use BSID-3 for developmental assessment of the babies. Now, as we have already seen, the ophthalmic assessment of the babies is important, which is done at the age of 4 weeks in the babies who are less than 1750 grams and less than 34 weeks of gestation. You repeat it if it is abnormal till retinal vasculature is complete. And one also requires to look at optometry at a corrected age, 2 months of corrected age, to find out whether there are any problems like myopia in this baby. For auditory evaluation, we do the screening BERA in an NICU graduate, and it is very easy to remember that you have a rule of 136. So by the age of 1 month, you screen the babies. By the age of 3 months, you confirm the diagnosis. And by 6 months, the babies are given hearing aid if required, so that their language development happens, in a proper manner. Now, then comes is an early intervention. So if the baby has any problem, what do we do? To provide therapy to this baby. So early intervention consists of identifying a baby who already has a problem or the baby who is at risk of developing handicapping condition, and you provide the remedial measures to lessen its effects. Is called as early intervention. And what early intervention we use at our hospital is a Bobath therapy. It is based on 2 basic principles. One is that you inhibit what is the abnormal tonic reflex activity the baby has, and you stimulate or you reinforce whatever is normal. So you facilitate the normal higher integrated writing and equilibrium reactions in their proper sequential development. So you stimulate that, and these are the basic thing which is done by occupational therapy department in our Kangaroo Mother Care Center. And these are the various things which are used for the treatment of babies like this. Here you can see the baby is just the age of 2 months, but you can see that the head control for this baby is too good as far as the 2 months of the baby is concerned, 2 months of age is concerned. And here you can see that the baby is, standing with, you can make out that there is an abnormality. The head the extension of the head, and even the baby has, the spasticity in the leg. So for all this treatment, you require the center for looking after this. Now, when we look at our KM follow-up data, this shows you over last 15 years, and you can see that the follow-up is somewhere in the range of about 65 to 70%. And the reasons for this optimal follow-up, what we gather from our data, is that the antenatal registrations at KM hospital are for the high risk delivery from a distant places. Now, those are, the national, low birth weight rate is about 18 to 20%. Our low birth weight rate is somewhere about 30 to 35%. And so we have more babies who are of low birth weight. There are long distances to travel. There is huge traffic in Mumbai, and traveling in the crowded public transport is a real challenge in Mumbai. Plus, there is a less support in the nuclear family. The father has to go back to work. So that is the reason why we have suboptimal follow-up as far as the KMC is concerned. But the babies who have come for follow-up in the Kangaroo Mother Care, they have come, so you can see here, they have come, each and every baby has come more than 6 to 8 times a year. And these are the total annual visits we have received from these babies over last 15 years. Now, we had a study which was follow-up study, which was to study the impact of duration of KMC on mortality, morbidity, on hospital stay, and on breastfeeding. And we divided into the group which received Kangaroo mother care less than 6 hours, 6 to 12 hours, 12 to 15 hours, and 12 to 20 hours, and more than 20 hours. And one can see that exclusive breastfeeding was universally found very good incidence in all the groups, and that's why you don't have a p-value which is significant. So the exclusive breastfeeding in these babies, when these babies came for follow-up, was more than about 90%, which was very, very satisfying. And when we look at the growth of these babies, this is another study on the different cohort which was done, which showed that we looked at how much was the weight gain per kg per day, length increase, and the head circumference increase. And again, looked at as per how many hours of KMC these babies had received. And we saw that even at a follow-up age, subsequently, the baby's weight gain was 10 grams per kg per day. The head circumference, the length increment was 0.6 centimeters per week, and head circumference was 0.58 centimeters per week. This is what we see in our Indian babies, that increment in the length and increment in the head circumference of the babies is not so much satisfactory as compared to the weight gain in the babies is concerned. When we look at the weight group of 1500 to 1800 grams, there were similar observations that the weight gain was 10 grams per kg per day, but the length and the head circumference was somewhere about 0.6 centimeter per week. Again, the same observation in the different weight group. When we look at as per the gestational age, the babies were less than 32 weeks. They again had a weight gain of about 10 grams per kg per day, and the length and head circumference was 0.6 centimeter per week, and the head circumference was still lower than 0.54 centimeters per week. And we are concerned because it actually tells you the growth of the baby's brain. So this is for the babies who are less than 32 weeks. And if we look at the babies between 32 to 36 weeks, again, the head circumference and the length increment was in the range of about 0.6 centimeters, where we actually expect somewhere in the range of about 0.8 to 0.7 to 0.8 centimeters per week. So this is what we have looked at, learned from this particular study which we have done in the follow-up. That's why we did again a knowledge attitude practice study for these babies, that what does these mothers are, what is they have understood from Kangaroo mother care. And when we interviewed these mothers and when we spoke to them, what we realized is that the most of these mothers had a positive attitude for Kangaroo mother care. More than 75% of the mothers had good knowledge regarding Kangaroo mother care. Their Kangaroo mother care hours increase after discharge at home as compared to the hospital. Most of the mothers, more than 63% of the mothers, were able to give more than 12 hours of Kangaroo mother care at home, and the family members greatly helped them in providing Kangaroo mother care. With help of the even elder siblings in the house, the mothers were able to give Kangaroo mother care. The areas of concern were that the heat, sweating, and discomfort were reported in this particular cohort by more than 50% of the mothers. Sometimes it depends in the weather in Mumbai, and in most of the, when in the summer season, these were the complaints by the mothers. And another area of concern was that the mothers were not able to express breast milk while providing KMC. So every time when they have to express the milk, they would take out the baby from KMC, put the baby, and then express the milk. So automatically the hours of KMC will go down. So looking at this particular thing, especially the second concern, when the mothers are not able to express the milk while the baby is in KMC, we did a quality initiative study, and we looked at that what is the reason for this. And then we realized that, of course, it started with us, that is healthcare workers, that they were the people, the healthcare workers were unaware of the policy. The shortage of nurses, because, you have at times one nurse managing more than 6 to 8 or even at times more than that. There was lack of awareness amongst mothers that they have, that they can express the milk while baby being in KMC position, lack of awareness among healthcare workers, lack of motivation amongst healthcare workers, because breastfeeding and KMC is something not very glamorous. So there was a lack of motivation. In hospital, adaptation was not practiced optimally. When you discharge the babies or when the babies are there in NICU, we have to do yeah, the family to family counseling to each family, which was not done very optimally, physical discomfort after LSCS, and no separate KMC ward in our institution. Probably these were the reasons why, the mothers were not able to express in KMC position. So we looked at policy, people, procedure, place, and we changed the thing. We did this quality initiative, and subsequently, by the end of about 4 to 6 weeks, we have most of the mothers expressing the milk while baby is in KMC position. Now, with all this, when we look at sustainable development goals, we talk about good health and well-being at all ages. And if we look at goal within the goals, that is goal 3.2, talks about ending the preventable deaths of newborns and the children under the age of 5 years. And answer to this, to achieve this goal, what we require is implementation of Kangaroo Mother Care. Similarly, the goal within the goal of 3.4, that is to reduce the preterm mortality by 1/3 by the year 2030. And this also can be achieved by using, by implementing Kangaroo Mother Care. And we also want their mental health good and good well-being. And I think the answer to this is the implementation of follow-up care programs and implementation of KMC, early detection of problems, and giving them timely intervention. So take-home message is that the upscaling of follow-up care services is the need of the hour in India, and the regular follow-up is mandatory for early recognition of high-risk infants for timely early intervention therapy. My thanks are due to Bill and Melinda Gates Foundation for providing grant to establish the Kangaroo Mother Care Centers and for renovation of Kangaroo Mother Care Center for initial years. We also thank National Thermal Power Corporation of India, Shantilal Sanghvi Foundation for subsequently supporting our program, and facility-based newborn care initiative of Ministry of Health and Child Welfare, Government of India, subsequently supporting our program going on till now. And of course, this is, the no work is complete unless you have a good teamwork. The top picture shows us the team which started with Kangaroo Mother Care when we implemented it in the year 2003-2004, and subsequently over the years, everyone has contributed to the success of the program. And my thanks are due to all those who joined the journey of KMC follow-up program at KM Hospital, Mumbai. Thank you very much.
Thank you very much, Dr. Ruchi. Am I audible?
Yes, ma'am. Can you go ahead?
Yeah, please. We will have question answers at the end. So we request all the presenters and the participants to remain. Now I have to introduce Dr. Sumita Ghosh, who is our special invited guest for this evening. And she has, in spite of her busy schedule, she has agreed to spare some time for us. She is the Additional Commissioner in charge of health, child health, adolescent health, safe abortion services, aspirational district program, and so on. And she is working with the Ministry of Health and Family Welfare in multiple stages, in multiple positions. And she has got a lot of clinical experience and experience of training and administration in government. With this brief introduction, I will request her to start her presentation. She has to go in a hurry. That is why I am stopping here. Thank you very much, Dr. Sumita. Please start with your presentation.
Dr. Sumita, you want me to share the presentation or will you be sharing? I can share it for you if you want me to share. Madam, we can't hear you. We can't hear you.
Sir, just ask her, like.
Yeah, please help her out.
मैडम तो म्यूट नहीं है, but we
नहीं,
can't
मैडम
hear.
म्यूट नहीं है, लेकिन उन्होंने ज्वाइन कौन सी डिवाइस से किया है? मैडम, from which device you have joined?
Computer दिखता है मुझे. I think it's a computer.
It's computer. Then I don't know if she has.
I'll ask her by phone.
Yes, madam.
Yeah. Ma'am, phone से बात कर दी because I don't think she's not muted, but we can't hear her. People can ask questions in the chat, and if you have seen
Hello.
already.
Madam, you require any help? Yeah, we are not able to hear you. Can I ask our people to help you out? Okay. Dr. Mohit, is she muted from there?
No, she is not.
And she needs some help.
Okay. Madam, can.
Okay. So we will continue with question answers and she will rejoin now. Huh? Okay. In the meanwhile,
madam, just tell her when she rejoins, she has to take the option of using the computer audio. Along computer audio, she has
madam,
to
you
play.
will have to use the option of computer audio, I believe. You have. And okay, thank you. Yeah. We will be rejoining soon, but in the meanwhile, I would to be answered. The first question is to Dr. Niels. Are you there, Dr. Niels?
Yes, I am. Hello.
Yeah. So can you answer the question whether KMC can be done during cesarean also? Means
Yes.
after cesarean section.
Yes, I sent a note to that. Certainly on full-term
No,
babies.
I wanted everybody to listen to that because, yeah, please.
On full-term babies, it's very easy and straightforward. It requires a different set of thinking and some training and some preparations. And having got the skill set of doing it on full-term babies, yes, it can be done on very smaller babies. Practically, the smaller babies may then require some equipment, and then we've generally shifted to the recovery room in the anesthetic environment. So there is a little bit of a distinction with the skill set required to accomplish the technology that preterm babies need at birth, specifically CPAP. Was that a good answer,
Yeah.
Shashi?
And another thing is how you do you insist on immediate drying and all these procedures? Can they delay the cord cutting? Can you answer those questions also with reference to cesarean?
Yes.
Yeah.
Our experience with the research that we've been doing in the last 2 or 3, 4 years, where we've also been working in Africa, India, and Scandinavia, is that we do thermal control very, very badly. And therefore, I would be emphasizing that we must take greater efforts and strenuous care to ensure that babies do not get cold. Yes, and that must start immediately, not the first 1,000 seconds, but the first 10 seconds. Was that answer to a question?
Yeah.
What was the rest of your question?
That is the thing. And delayed cord cutting. What is that? Yeah.
Yes. So I don't think there's any doubt that this is beneficial, but I don't think one needs to be too dogmatic and pragmatic, valuing that at the cost of other interventions that are also necessary. There's some nuance in the answer is necessary. Yes, we should ensure delayed cord clamping as far as possible, but we must also ensure safe provision of CPAP and ensuring of warmth.
One more question. What about those babies who require resuscitation, immediate advanced resuscitation? Can it be still done on mother's chest or you have to separate them?
It can be done. I personally have done it, and I know that Kim Luang Chi in Ho Chi Minh City in Vietnam has a lot of experience of doing it personally, but it also requires a great deal of confidence and a great deal of experience. And I won't hesitate to say, it's not going well, let me be more intensive and I'll separate the baby that needs resuscitation. But the early steps of resuscitation can indeed be done in skin-to-skin contact. on mother's chest. Sometimes I avoid doing an intubation on the mother's chest, not because I can't on the baby, but because the mother is in distress. So there's a number of clinical factors, reality checks that we have to bear in mind. But one can do a great deal on the mother's chest. Practically though, I want to say zero separation, yes. But if I take the baby away for 60 of those seconds that I wanted in the beginning, I do not believe there'll be any harm at all. I think it's a safe thing to do and a practical thing to do if one has any doubts at all, and then you can bring the baby back straight away. So the buffering protection of adult support toxic stress is when that is prolonged. And 1,000 seconds is a prolonged period. 60 seconds is not.
Right. So at least excepting for those life-saving interventions which get priority, rest of the time, as far as possible, we should try to have zero separation. Can we give that message? Okay, right. Okay, thank you. And one more question. Here, many times, just because the baby is high risk, they take away the baby and put under a radiant warmer or incubator for observation. Is it a good practice?
Please do not do that. That's not helping the baby. That means that the observations you're making are continuing to get worse all the time instead of better.
Now, any questions from the audience, please? I just put some of the common questions which are raised, frequently asked questions. But any other questions from the audience? Somsekhar, do we have any in the question box? Okay, then we request Dr. Natalie to answer some of the questions. Dr. Natalie?
Yes.
You did answer a few through the chat box, but the same one I would like you to answer again. Is the gestational age or the weight of the baby is related to duration of KMC?
Yes, I mean, I understand that it's not easy, but look, the problem of the premature infant is immaturity. Yeah, and immaturity for thermal regulation, immaturity for the gut, and immaturity of the brain too, yes, is immature. So what we want is to help him to mature in a safe environment. I cannot put it again in the womb of his mother, but I would be happy to be able to do. So your baby who is immature to regulate temperature, when you put it in skin-to-skin contact, he will have a perfect regulation. But when he is with the maturation and the time when he arrives around 38 weeks, is not tolerating more kangaroo position. And very often the mother will not say it, but the baby is sweating, crying. She take the baby out. He stopped crying. She put the baby in kangaroo position. He began to cry. So that's because he want to move. He want to be outside. And the best thing, it's I follow them, and with 20,000 infants, it is a growth curve, perfect growth curve at 38 weeks of gestational age. So some baby will stay a little bit more, some baby a little bit less, but it's really when the baby is regulating temperature. So what happened with the weight? The baby, if it is 32 weeks with 2.2, he will stay 6 weeks in kangaroo position, yeah? But if he is 37 weeks or 6 weeks with 1.5, he will tolerate it up to 38, yeah, 2 weeks or maximum 3 weeks after he will refuse the kangaroo position. That's really physiologic. So we have to accept it. And the best way to know if it's adequate or not, it's to look how he's growing. because if he's growing well outside the position at 39 weeks, even with 1.7, that means he's regulating temperature. So for this reason, the growth curve is so important. So I don't know if I was able to explain what the concept for us of kangaroo position.
Yeah, ma'am. Thank you, ma'am. It has been a pleasure. We will go to the next presentation. Dr. Sumita is online, and can we hear you, madam? We can see your presentation. Your presentation is already shared.
We will continue the question and answers after that.
Okay. Madam, can you start? Mohit bhai, what exactly is happening? Because madam ne to share kar diya hai presentation. She has shared a presentation. I can see that she is not muted, and we can see her on the screen. Madam, can you start moving the slides and speaking? Dr. Sumita, can you? Yeah, we can. We have gone to the next slide, but we cannot hear you.
Sir, I've talked to her on, and I've just told her to log in through the phone, and she can speak on the phone.
But she has logged in through the computer, I think, again.
No, yeah, she has logged in through the computer, but on the side by side, she can do on the phone also. Yeah.
No. Yeah, I think she's joining through the phone also, right?
Yeah. I've admitted her.
Yeah, madam, you can start. I think you have spoken through the phone. You can start. I think. आप phone से बात कर लो.
Yeah. Am I audible now?
Yes. Perfectly, perfect.
Yeah. Thank you. Thank you for this, because there might be some problems with the computer audio.
Madam,
I can tell you also,
madam,
I have been listening to all the very erudite discussions which have been taking place. I am very fortunate to be part of it. And I congratulate Kmc Foundation for organizing this international webinar on this National Newborn Week. And this is exactly what is in our mind also, in the ministry also, how, where the newborns, we can help out the newborns. And this, as we can see on the screen, India has a large cohort, 2.6 crores, that is 26 million babies are born, and 15-20 if we consider that they are either preterm or low birth weight. So then again that translates into a huge number. And with multifarious efforts, India has been able to reduce the NMR till 2018 reports we have latest, that is 23 per 1,000 live births. And as this the stalwarts who are present here already know that they are all in the first week, 78% in the first week. And the decline rate has been better than the global rate. We have been able to achieve 60% decline. So if we have to reduce further in order to achieve our goal of national health policy, that is 16 per 1,000 live births by 2025, and the INAP goal, Indian Newborn Action Plan goal, single digit by 2030, we have to look at these figures where the deaths are happening, and they are happening 50% almost, are in the premature and low birth weight. So our focus is already on this, and we are working towards it. And Kangaroo Mother Care, we know, is the single most effective step towards it, to reduction of this red, highlighted parts. These are all graphs you know better than me, I understand. So our focus has always been linked with Kangaroo Mother Care Program, which improves both the nutrition part, prevent infection, and the psychological bonding and the neuro development. So I am not elaborating on this. This again must be known to you that quarter of newborn deaths can be avoided. So it is always in our focus, because all these figures, they tell us that severe illness, hospitalization, they are reduced, survival is increased, hypothermia, and breastfeeding also. They are the important components. So I'm not, it is the most powerful intervention which we have in our hand for reducing mortality, and one of the very high priority areas. So brief about the journey. 2014, we have released the operational guidelines for rolling out the program across the country. It is in our country, we advocate less than 2000 grams because of the high load of prematurity we have, low birth weight we have, both at the facility level and also at the community level. And all the health facilities countrywide has been advised, guided, and they have adopted Kmc practices. We have, in our support to the states and duties, dedicated budget line for supporting the infrastructure required for Kmc, rolling out Kmc in the facilities, for various capacity building programs, operational expenses, IECs, and bringing special focus to Kangaroo Mother Care. So this has been our program since 2014. At the facilities, delivery points, we have, these are the most important interventions we are taking at the delivery points, promoting exclusive breastfeeding, care of small and sick newborn at SNCUs, and follow-up at DIC's district early intervention centers are there in our RBSK program, that is Rashtriya Bal Suraksha Karyakram. And Kangaroo Mother Care Program again is one of the very important component of our improving the of our efforts to improve the neonatal survival. And the first presentation I heard about the 1000 minutes. So 1000-day program is already ingrained in our health programs, and even 1000 minutes also the concept that physiological birthing, family participatory care at the delivery facilities, and also in the postnatal ward, and even in SNCUs, we have promoted mother and newborn care units, MNCUs, so that there is no separation, there are least separation, and separation, non-separation as much as practicable. So we have promoted that mother and newborn are together always. Interventions, various interventions are there. Strengthening our facility-based newborn care, SNCU, NBSU. NBSU is Newborn Stabilization Unit, which is little lesser than SNCUs, and less sick children, newborns can be catered to in these facilities. And at the delivery points, we have newborn care corner. After this, after the facility, there are a lot of emphasis of follow-up of these newborns by our community health workers. They are called ASHAs here, Accredited Social Health Activists. And we have right now more than 9.5 lakhs of health workers, such health workers who are doing community visits for various RMNCH activities, and now of course COVID activities too. So they are doing the home visits for the newborn, 6 or 7 visits, and they are being done on days, till 42 days, 6 visits, and for home-based homeborn newborn, 7 visits. So this is one of the very well entrenched program in our system for community follow-up. And we have recently added home-based young child care. So beyond 42 days, 5 visits are made at 3 months, 6 months, 9 months, 12 months, and 15 months for care of these newborns, giving them nutritional counseling, measuring their growth and developments. So these 2 programs in community look after the follow-up. And for those especially who are the SNCU discharges, the babies who have been discharged from sick units and the low birth weight and prematures, they are quarterly followed up till 1 year, which is ingrained in this home-based young care visits. We have another very ambitious program, that is RBSK, Rashtriya Bal Swasth Karyakram. In that, we have community-based activities as well as facility-based activities. Here, we are doing child screening for 4 Ds, that is the delays, developmental delays, deficiencies, disorders, and defects, birth defects. So this ambitious program, which from 0 to 18-year-old children, we are working on this, and under this, again, facility-based screening, and then Anganwadi-based screening and school-based screenings are being done, and these children who are identified with these 4 Ds, they are referred to proper facilities, and district-wise we have made early intervention centers to look after especially the defects and the delays, developmental delays that occur because of the sickness in the neonatal periods, especially our children who received kangaroo mother care, detecting any defect, any delay in them for their early childhood care and development. Our ECD program is there, that is first 1000 days program. Again, in that we have call centers which regularly look after the discharge, SNCU discharge babies, as well as babies who receive kangaroo mother care for monitoring their growth, their development, any signs of development delay. They go to the they call centers regularly follow them up. Again, our ANMs have been empowered with management of preterm labor, delivering kangaroo mother care, and breastfeeding support. So, follow-up mechanism which has been discussed till now, they are in our guidelines, as well as we have dedicated record mechanism for their feeding, their gain in weight, and the required information which need to be given to the parents by IC and audio visuals. These have been developed, and they are the key to good care, and standard indicators have been put in place. I believe we are one of the first few countries who have designated indicators for observing kangaroo mother care in our SNCUs. So from the records which are available, SNCU Online is a real-time real-time information system for us, in which we can monitor actually all the SNCUs, which are almost 900 of them are there now, and there we can see steadily the eligible program, children, newborns are getting kangaroo mother care, and as of late, last year, 42% of eligible babies got kangaroo mother care in this SNCUs. This dedicated monitoring indicator actually help us tracing this, how the kangaroo mother care is promoted and whether the SNCUs are doing it or not doing it, and then accordingly we monitor and advise and guide the SNCUs. Regular follow-up is being done by the professionals, by the trained providers at SNCUs and DEICs up to 1 year. This already I have said that community level we have the system in place. Screening for babies, preterm babies at DEIC. We have the regular procedure and we have packages for their management. So globally, these are the interventions, early childhood development interventions, and we all know this, that it starts at the adolescent and adolescent period before pregnancy occurs, continuing into the pregnancy and through labor and birth, then neonatal, infancy, early childhood period up to school age period. So most of the interventions which are mentioned here are adopted by Government of India and they are in place. Guidelines have been issued, states are following it up. Intervention like what was being discussed here, the mother-child bonding, the psychosocial stimulation, positive parenting, responsibility, all these are part of our program itself. We have maternal health program also, so that the stress, the anxiety, they are taken care of during the pregnancy and postpartum period. For the financial security of mothers and the families, we have social protection and conditional cash transfer for the below poverty line families. That is in place through our programs and direct benefits are transferred to them. Again, WASH program we have encouraged. Additionally, we have the recently launched insurance-based program, which is Pradhan Mantri Jan Arogya Yojana, and we have special packages for preterm babies and for sick babies. So we are they can take treatment at any approved private institution also, and then get reimbursed according to that insurance plan. So ECD implementation we have at the facility level, community level, home level, at various through various mechanisms and through IEC and capacity building of the providers. The funding and the resource, human resources are supported by the National Health Mission, and they are, the states, they project their needs, and we, from the National Health Mission, the supports are being provided as per their needs. So here are few of our pictures, how it is being done at the facility level. When at the DEIC, the first picture is DEIC. You can see the beautiful, beautifully decorated and developmentally supportive pictures, which are part of our DEICs. At facility to admitted, even you can see the males are also providing kangaroo mother care, and the last one is at NRC, Nutritional Rehabilitation Center. These pictures are of the various community level platforms which we use for promoting ECD, that is Village Health and Nutrition Days happening in villages, every month. We have parenting workshops, mothers group meeting, both prenatal and postnatal, and home visits under ASHA's for HBNC and HBYC program. So the messages that are given, these are some of our IEC materials, which are, they are about developmental delays, how to detect it, at what age, what is appropriate. We have a very, very beautiful guidance on 1,000 days, first 1,000 days, and which from the conception day to till second year, we have outlined and guided the states what are the expected things and what need to be done to support early child development. ECD call center, I have said that they make regular calls, especially to these preterm babies which receive kangaroo mother care as a follow-up and receive discharges. And parenting support is given through this call, and developmental milestones are informed to the patients, to the mothers and parents, so that they can follow them up at the home. We have this app, Ayushman Bhava, first 1,000 days. So here it empowers the families to, be aware, to be informed, and to help them out with monitoring the development of the babies. So to end, I would say that, through all these SDG goals, which we are addressing through early child development, are being addressed by us. We have continuous, consistent efforts towards babies, especially the preterm and the low birth weight babies, especially those babies which need skin-to-skin contact and need that initial support for the lack of because being born early, the contact they have lost early. So for them, we have several programs, and we do believe that various innovations, various researches which has been presented today, they will guide us in future for fine-tuning our programs further, and we will definitely look into it, because the survival, if we can control, the thrive part we have to address properly through the follow-up mechanisms. Thank you very much. I must appreciate the presentations. Already I have gone through them, like I was listening through them. Dr. Niels, Dr. Natalie, Dr. Ruchi, Dr. Rekha Udani, who are working such extensively in this field, and also the KMC Foundation, Dr. Vani, Dr. Somshekar, everyone I thank for giving me this platform to project government efforts, and also as a learning experience for myself. Thank you very much.
Thank you very much, madam, for your excellent presentation. This was the main purpose with which we had called this meeting, that we have some plans are there, but a lot of gaps are there we need to fill up, and we have to universalize these facilities and programs, because DIC, for example, it is there working in very well in some of the places, but not yet reached many places. Like that, we will take up these discussions sometimes, but I am really happy that you have taken so much interest, and that augurs well for us for the future. Thank you very much.
Thank you, ma'am. If there are any questions, one of the questions that was there for Madam was as to how can we go ahead in the future, and in what way can the government help getting ASHA workers even more interested in this. And that's what I think that was one of the questions that was asked. Anyone have any other question?
Madam, if you can stop sharing your screen, please. Dr. Ghosh.
I can. मैंने कर दिया.
Thank you.
So if there are any questions, there are a lot of questions that have been answered, and we can highlight some of the questions that are there. So one important question that was asked is how can we motivate fathers to do kangaroo mother care in the NICU? And Dr. Parag and Dr. Niels have explained that their fathers are actually very eager. And Dr. Natali has actually also said that because the father usually would have a temperature which is slightly 1 Celsius grade more than his wife due to the testosterone. And if you explain that to the father, then that might be even more useful, and you can get fathers to cooperate. Dr. Niels also said that there can be a dopamine surge in the father's brain and making them committed to the infants if they start giving skin-to-skin care in the first few hours. We are already going past time, and we have answered a lot of questions.
Now,
so
can I request Dr. Nathalie to say something?
Yes, please go ahead.
Yeah. Nathalie, you have listened to our government presentation, but
Yes.
if you have any suggestions, or
there is
even generally
one thing,
also, yeah.
there is
please.
one thing that I was asking myself. I think that each time more people are thinking in the premature infant with a gestational age. So I really want to insist that the follow-up must be done in corrected age. Yeah, it is very important, because if you take a baby who was 32 weeks, one is 40 weeks, 3 kg, is beautiful for me. But if you look at him with WHO curves, and you say that this baby who was 32 is 2 months old, 3 kg will not be the same. Yeah, it will be, oh, you must give something else to your baby, is not well nourished, look at this kind of thing. So it is, and perhaps the mother will give artificial milk because they are telling her that it's not sufficient in breastfeeding. So it is very important to think with a follow-up in corrected age, because even in neurological development, in psychomotor development, I will not ask at 6 months of corrected age the same than a term baby at 6. I mean, I need to put this baby in corrected age during the first year. Yeah, because the baby cannot jump. If he was 2 months less or 3 months less, you must give to his brain the time to, yes, to mature up to 40 weeks, then to do, he will do a catch-up, okay? He will do the catch-up after, but we must let him do it with the stimulation of the environment and this kind of thing, but we must evaluate this baby in corrected age. Are you agree with me, Dr. Rekha and Dr. Nanavati? I mean, it's very important.
Yeah.
Yeah, it's very important. So in the follow-up, which was presented, I think it's important to put that whenever possible, the follow-up must be done in corrected age, whenever possible. When you have gestational age, when you don't have a gestational age, perhaps you can evaluate it. But because the mother know when she was waiting this baby for this date or not. I mean, we have to try to think like this.
In another important question is, many of our field workers, they are not in a position, many of our community-based workers, they are not in a position to estimate the gestational age and other details. So can we use in that purpose post-menstrual age as a...
I think we are using everything we have. But you know, we have a small video on the Ballard test that it's not so complicated. It's not so complicated to teach to your worker. I mean, it's possible. Yeah, and I can send you the video if you want.
Yes. Yeah, we would like
to. Even in English.
Okay, right. And any other questions from the audience?
Dr. Niels, can you go ahead? Yeah, Dr. Niels wanted to
follow on from what Natalie said and your question, Shashi.
Yes.
I think for the Asha, for the person at the village,
yeah.
My suggestion would be put that baby skin to skin, even if it's for pure compassion.
Yeah.
Now, that baby might be smaller than you think. Even for me as a doctor, it's hard to tease out SGA and preterm and low birth weight and those kind of things. But for that baby, it deserves zero separation, even if it's palliative care. Now we'll find that such a baby didn't palliate. It responded positively. And then what I've kind of suggested is that to the Asha and the mother, if the baby opens his or her eyes, it's a signal that you should fight for that baby. If the baby closes his eyes, her eyes peacefully, then let it depart in peace. Now, somewhere in between there's the sense of living far, far away. But in the meantime, we've provided compassionate care. We've provided the child's best interests, never to be separated. So I would make this appeal.
Yeah, so at least in our guidelines, which we have prepared for the care of the babies in remote areas, I have told them, all the babies, you can put them on skin-to-skin contact. You don't have to say whether it is low birth weight, full term or this. The mature babies will leave soon on their own. So babies will decide whether they want to continue with KMC or not. So the question sometimes which people ask there, why one baby is given this care and why I am not given that care, that is also nullified there. So that is what we are advising, at least in the remote areas where no other help is available, only the community health worker has to do. So we don't make a distinction. We say as soon as the baby is born, put them on skin-to-skin contact. Let the baby decide whether it wants to continue there or leave it. So, am I okay?
Madam, there's a question. There's a question that Dr. Ashutosh Mahapatra has asked. I think Dr. Niels and Dr. Charpak can answer.
Yes.
Whether there is any hormonal impact in kangaroo mother care for babies. He has earlier talked about oxytocin, but can you please explain, Dr. Niels? Hormonal impact of KMC.
So there's a number of such studies, and we call them signaling hormones. They're particular hormones that are working at birth, and all of them work together. Oxytocin is the first, dopamine, vasopressin, some endorphins, and they also work with cortisol and norepinephrine, epinephrine, adrenaline, and noradrenaline. And it's the package of those that are regulated and set at a certain point. So I understood your question. Have I answered it? Yes, there are many such studies. You can show that those things are taking place, but it's quite difficult to then make the statement that this affects the outcome. You're showing it as physiology. You're showing it as the normal kind of expectation. Then I'm saying separation disrupts that. But now separation has become normal. So we're answering the question in a different way. Am I digressing?
No. Yeah, Dr. Natali, please go ahead. Please go ahead.
No, yes, on the infant, I first want to say to Dr. Sashi Vanik that there is something, put the baby immediately in skin-to-skin contact. And for people, if the baby reacts and the baby is, you think the baby could survive, perhaps you can think about transportation.
Yeah.
I mean, that's possible. It's a perfect transportation. in kangaroo care and with something of colostrum. So think about that too. Yeah, for the a good surviving, no? That's important. The second thing I want to say, on the hormone in the infant, we didn't find in our study a lot, but I want to tell you that actually we are writing a paper because we are slow. I know we are slow because of a lot of work, but what we found at 18 years is that the gray matter, Niels, look at that, the gray matter and all the nucleus of the base, which is gray matter too, are dependent of the duration of the kangaroo during the neonatal period. Can you imagine? I mean, it's beautiful. Yes, because you can try to associate that to some tests. So we look at the fine motricity, memory, IQ. So it's a small effect, but 18 years after, 18, 20 years after. So that's very interesting. So for this reason, I was insisting that the brain is immature. So this immature brain, the fact that you put it in a less stressful environment have an impact. So that's very important, no? I mean, it's nice.
Right.
Okay.
I would now suggest, can we go ahead to the next part,
Sir,
because I think
we have already overshooted, sir. We
May
have
I make a point?
already overshooted, sir. 30
May I make a
minutes.
point?
Yeah, madam.
Yeah, I just want to say that the KMC is actually our normal biology, and the brain development is normal in a normal place, that is skin to skin contact with mother. So rather than proving how KMC is beneficial, we should be studying and describing the harm to the normal brain caused by the toxic stress that follows the infant and mother separation. So rather than this thing, so we should be doing that. So that is our whole thinking requires to be changed, that what is normal, what is bad for the baby is bad, and we should stress on that. That is one. And just additional point that, in country like us, many people don't get paternity leave or this. So we can involve the fathers in giving KMC at night. So that's what we do in our unit. So the fathers, they are in the unit at night, they give KMC so that mother also gets some time to rest. Thank you.
Dr. Mohit, can you please summarize and then ask Dr. Snehal to close the session, because I think we are late already.
Yes, sir. It was very nice session, like especially for neonatologists like me, like we have, like neonatologists like me, we have our head all stuck in cardiac and in ventilation. So we are just stuck there. We don't think about all other these things. So, and these are the basic, very important things. And I still remember Shashivani madam meeting me like 3-4 years back, and then I got insisted, and now because there was issue of KMC in our NICU because of the privacy, so we have started shifting babies with warmers and everything to the mother side at 700 grams, 800 grams, and we have been doing, and the babies, we are able to decrease our sepsis rate and babies weight gain and everything. So this has changed the outcome in my NICU. So my head got out of this, and the whole session, Dr. Niels, Dr. Nathalie, Udani madam, and Nanavati madam. So all those things, they were, giving the same message, and the research and everything was giving the same message. And this was very helpful. I would again like to thank all of them for being here, especially Dr. Nathalie. Like, I think so it's early morning over there, and she is being so actively involved with us on the, and especially there are so many people like Dr. Alok Bhandari is there, Dr. Lalan is there from the Central NNF, and we got a very encouraging remarks even on the groups by very big people like our President NNF, President IAP, Dr. Digan Shastri, and we have our many main people are being logged in. So I thank everyone, and the message is clear and out for everyone. Hanji sir.
Dr. Mohit, the next NNF president, Dr. Sandeep, also is there.
Yeah,
Maybe
he's
he can
also
speak
there.
a few things, and we hope we can get his commitment for next year for KMC also.
Thank you very much, sir. To invite me and continue next year for Kangaroo Care, Mother Care, and Dr. Douglas Saib also, and sir, you also most welcome anytime and give the suggestion for that, and we are going to continue NNF and KFC Kangaroo Mother Care in next year also. And
thank you.
We are going to in periphery with a small place. What for a few groups is there. Each and every town for gynec and pediatric staff is available for that, and we are going to continue to train that people also.
Now, Dr. Niels, you have put in a very good thought in our mind. From 1,000 days, you have shifted us to 1,000 minutes and now even 1,000 seconds. So I think that concept also everybody will carry. Dr. Nathalie has put up the fine-tuning of the follow-up programs, and Bombay group has shown us that it is possible to do it even in India. So we should have more centers like that. And of course, Dr. Sumita Ghosh has told us already what are all the things there in government planning and programs, but that requires a lot of fine-tuning. Not only fine-tuning, even gross tuning also is required, universalization is required, a lot of things are there. So on behalf of KMC Foundation, I thank each and every one of you for giving us some good messages, and all the participants who have given us good feedback and interactions, and all our organizers, Dr. Mohit Sahni and his team, Dr. Somshekhar and all your groups, and all the other participants who have assured us that they will continue improving KMC in our country, our state, and many places. Thank you very much. Yes. Yeah, please let him go. Yeah.
Dr. Snail, can you?
I'll give the official vote of thanks.
Yes, go ahead, please, and then we'll stop.
Yes, everybody has said a lot of things. I don't have much to say, but it was a fantastic event. It was participated, at least I saw 161 participants at one point of time. It could have been more or less, I do not know. But thank you so much to Shashivani Madam, KMC Foundation, and Dr. Somshekhar at the outset, who were the pole, who were the center around which everything was hinged around. Dr. Mohit Sahani, who was the president of NNF Gujarat. More importantly, we get to hear today from the people who have started KMC. It is so nice that Dr. Niels and Dr. Nathalie, who are the pioneers, and we had a direct interaction with them. Dr. Ruchi and Dr. Rekha, what do I say? I have been hearing, I was from Bombay, so I've been hearing them since ages as an undergraduate student, and it was always so nice to hear the always great speakers, Dr. Ruchi and Rekha. Dr. Sumita Ghosh was important because government participation is the most important over here. At the last outset, let me have only one word of everything. Till the time I kept on training my staff to do KMC, they would not do it. But KMC program arranged by Dr. Somshekhar only. And once after they came back, KMC really